I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Welcome to everyone in the room, all of those joining online via YouTube or Facebook Live or coming back to watch us post live. Welcome to all of you too. We are so excited to have everyone here tonight, and of course, our guest speaker, who really needs no introduction.
His Excellence.
His Excellence, Dr. David Gandara from UC Davis Comprehensive Cancer Center. You guys have either seen him here in the room, watched him on video, or heard us talk about him at almost every living room. He comes up in some form or fashion. So we're really excited to have him here tonight to talk to you all about personalized cancer circa 2019. Where are we today, and what does personalized medicine look like today compared to how it has looked like in the past, and where's it going? So we're excited. We're going to start the same way we always start with the around the room introductions. Please feel free to tell us who you are, when you were diagnosed, what you were diagnosed with. You certainly don't have to talk if you're new to this meeting. It's not required that you pick up a mic and introduce yourself, but we definitely encourage it. And anyone online who wants to say hello, Dr. Amy Moore, our Director of Science and Research, is on, as well as Michelle Zay. So they're there to field any questions you have and or to make any introductions on your behalf. I will go ahead and start. I'm Danielle Hicks, for those of you who don't know who I am, and I oversee patient support services here at GoTo Foundation. So anything and everything that has to do with patient touch is my area of responsibility. So if I'm not doing something that you'd like me to do, or if I'm doing something you don't want me to do, give me a call, and we'll fix that. I'm going to go to this lady on my right, who also doesn't need an introduction, but tell us who you are, and then we'll shoot around the room.
I'm Danielle and Andrea's mom.
Jared, too.
And Jared, I have a son, but you don't see him often, but he's working and he's out there doing a good job. I'm Bonnie, and I just love you all and so excited about all of this. So proud of my daughter who's leaving, and Michelle, because the living room has been on the road. They've done a living room in Toronto. They've done one in Florida. We've done one in Spanish. We've done one in Chinese, which with David was helping us with that one.
I didn't do the one in Chinese.
Right. But we're doing one in Mexico City, and they're leaving in the morning to go do that. And David's going to be at the adjoining meeting that's going on down there. So we're on the road and taking this globally, all over the world. And it's so exciting because, patients to have access to people like Dr. Gandara and others is huge. It's really huge. We can tell you all kinds of things, and you go, yeah, well, okay, that's good. But when somebody like David and some of the other people that we host here tell you, it's really extremely meaningful, and it's about surviving. So that's me.
Thanks.
Yeah, and I'm a survivor.
That's a little side
Small
note.
thing.
Yeah.
Yeah.
I'm ready.
Okay.
Go, Don.
Good evening, everyone. My name is Don Stranathan, and I'm a 10 and a half year stage 4 lung cancer survivor. And welcome, Dr. Gandara. And I know you've been traveling the last month, so I'm glad you had safe travels. And since the last time I saw you, and I've been on one type of treatment or another for the last 10 and a half years. Recently, in the last 30 days, I found out I had some brain metastases. So I just finished 3 rounds of CyberKnife at South San Francisco Kaiser to resolve the brain mets issue. And then I had, which Bonnie was so nervous about it, she wanted to send me to the doctor a couple months ago when I was here at the living room.
Right.
But I had some progression on my neck, which is clearing up. So, and I had 15 hits of radiation to my neck. I also had 2 tumors in my dural matter that my radiation oncologist in Rohnert Park that was doing the neck suggested, well, we could do whole brain radiation to your head and hit the dura mater at the same time. And I said, absolutely not. If anything, I'm going to get CyberKnife. So I felt very fortunate. The woman that was doing the CyberKnife said, well, don't touch the dura mater. We'll get it when he gets down here for CyberKnife. So they didn't have to go into the brain, and that preserves, I probably won't want to do whole brain radiation, but if it ever became an issue where I needed to, I have that on the table at some point. So, thanks.
Thanks, Don.
Hi, I'm Tim Gonzalez. Was diagnosed with stage 3B adenocarcinoma, non-small cell lung cancer in August. Right after Don's 10-year survivor party, I was diagnosed a couple weeks later. So I'm not unfamiliar with the people in Don's group, and I couldn't be more thankful now that I do know all of you. The support that I've received from everyone in the lung cancer community has really been overwhelming, and it just brings tears to my eyes. It really does. I think a lot of you people, and I know for sure know now where you're coming from. But I'm receiving treatment, carbo and Taxol right now, and 35 hits of radiation, I think, to try to lower or lessen the size of the tumor in my chest. And it seems to be working. After chemoradiation, I got 2 or 3 days of pretty extreme chest pain, and I think what they're doing is working. I think it's putting a hurt on the tumor, which is kind of putting a hurt on me, but that's okay. But thank you so much for being here. I'm very appreciative that I have a place like this that I can come to. So.
Thanks,
You have
Tim.
to know something about these two. Most people in the room already know this. These two have been friends for decades. And Tim, when Don was diagnosed, Tim was his buddy, right? He was your cancer buddy and his caretaker and all of those things. And then, lo and behold, Tim gets lung cancer. So now these two are buddies for each other. You can follow them on Facebook, and it's just so heartwarming because they're both they line up their radiation treatments one after the other, so they go together, and it's just an amazing story of love and friendship, and it's just nothing but goodness. Yeah.
Penny was very instrumental in helping me.
Okay.
Sorry.
Tim was very instrumental also in my caregiving with my girlfriend Penny that lived in New York.
Right.
He was the one that would show up at the airport at 2 o'clock in the morning
Yeah.
to get us home.
And Penny passed from lung cancer.
Right.
Who knows? How does all this work? I don't know.
She had small cell, right?
Yes.
So I'm going to come back to that later.
Okay, great.
Great.
Okay.
Right.
Sorry for the interruption.
Thanks, guys.
Okay.
Hi, I'm Jennifer. I was diagnosed in August of 2018 with non-small cell lung cancer, stage 4. I had mets to the brain, had it in my C3 spine, had it adrenal gland, hip bone, and everything's been treated, CyberKnife and chemo, and I'm stable now. I had EGFR20, or have EGFR20, with a PD-L1 expression. 31 to 40%, I believe, is my range. But I'm currently on Keytruda and Alimta, and it's keeping me stable, and that's all I can ask for. Thank you.
Thanks, Jennifer.
Hi, everybody. I'm really privileged to be here tonight with all of you. My name is Christy. I work for Loxo Oncology, and my passion and my job is to help patients get genomic testing. So if anyone has any questions around that, that's what I'm most passionate about. So thank you all.
My name's Joyce. This is the first time I've been here, but I was diagnosed in the spring of 2016, and I have an EGFR kind of cancer, and I was 3B, and I'm still playing golf. So,
Nice.
So as far as I'm concerned, things are working. I've had chemo and radiation. I took Tarceva for a while, didn't like that pill. Took Tagrisso and have been on that for, more than 18 months. So that's working, which is, I agree, awesome.
That's awesome. Yeah.
Thanks for coming, Joyce. How'd you hear about us? Just curious.
Well, actually, I've always gotten things from you because I'm going to get all choked up. I had a really good friend, Susie Nagpal. Do you remember her? Who died of lung cancer. It's quite a while ago now, but we were very good friends. And she was very involved, I think, when you were more of a startup. Mm-hmm. So today, even though I've always gotten your things, I never paid attention until whatever this email was. I looked at it and decided I should come.
Oh, we're glad you're here.
Welcome.
Thanks.
Awesome. You're in the right place.
Hi, I'm Jane Millman. In 2012, I slipped on my front steps and broke a couple ribs. And in that x-ray, it was found that I had a spot on my lung. And the results weren't so good because it turned out to be stage 3 EGFR lung cancer. I had a lobectomy, and then I followed up with chemo. And ever since, I've had clean scans. So I'm a grateful Jane Millman.
Thanks,
It's
Jane.
called divine intervention.
Hi, my name's Larry. I was diagnosed in January of 2013, the same week as Jane. We've been friends for a long time, and we were diagnosed in the same week. So that was, I don't know if you call that divine intervention.
That's just strange.
Yeah.
But I was stage 4 adenocarcinoma. I have EGFR mutation, exon 19 deletion. I'm on my 3rd systemic procedure. Started with chemo. I'm now on my 2nd targeted therapy drug. I've been on it for 3 years with good scans, good results. One part of my story that I haven't talked about before that I want to talk about tonight is the living room. I think the living room, although it's hard to quantify, has something to do with why I'm being successful in my treatment. I've watched or been here for every living room since I was diagnosed. And occasionally, a couple times a year, a very wise lady by the name of Bonnie Adario tells us that studies show that patients who are educated, empowered, and proactive live longer. So I want to encourage everyone to learn about your disease, about your lung cancer, and be an active participant in your treatment.
Thanks, Larry.
Well said.
Jeez.
I know. Here we
Jeez.
go.
We have to go.
Here we go.
Hi, everyone. My name is Rick Meyer. I am ALK positive, stage 4. Was diagnosed back in November of 14. So on November 7th this year, I'll be 5 years. Happy about that. My original diagnosis was ALK positive, I guess through a fish test. I guess this is for Chris. So the problem is we haven't been able to get any new tissue samples to get any late data. So we're basically going off 2014 data. I guess that's great because there's not a lot roaming around, but meanwhile I have brain mets that are pretty persistent. So picking new drugs is just basically like throwing a dart at a dartboard as opposed to having the data to be able to pick the specific right one. So that's a challenge that I'm facing. Other than that, quality of life is great. I'm on my 4th protocol with meds and plan on being around for quite a while. And I agree with what you said about the living room. This is a great organization and a great, great group of people. And if we all stick together and fight the fight and get the word out there, we'll get progress on this disease and hopefully just completely annihilate it.
Thanks, Rick.
Thanks.
There you go.
Hi, I'm Rick Grayson. I was diagnosed February of 2015. I didn't have any of the genetic mutations, so I got to go straight into old-fashioned chemo. It was carboplatin and Alimta. The Keytruda wasn't out at that point. But it worked pretty well for 8 months, and then I had progression on my adrenal gland, and that was my only active tumor, so they were able to surgically remove it. And then I was on chemo for another 4 months after that. So I went through 12 months of chemo. And in February of 2016, I had my first clean scan. And every scan since then has been clean as well. So I'm currently NED, no evidence of disease. Been really fortunate to have found this living room through the Stanford Lung Cancer Support Group and Tina and Rick. Wonderful advocates for everything.
Where are those two? Are they on vacation?
They're traveling.
It just means extra wine for people tonight. Yeah.
I'll drink all of Tina's white wine. Right?
Yeah, so things have done pretty well. I had one complication after I was taking Lovenox for to keep as a blood thinner during chemo, and after I stopped my chemo in 2016, then a year after that, I developed a blood clot in my thigh that swelled up like a balloon for a couple weeks, and then had to get that cleared out. I've been treated at Kaiser Santa Clara, and have been really pleased with my oncologist there, Dr. Dutia. So.
That's awesome. Thank you.
Thanks, Rick.
Who are you? Who are you?
My name is Barbra Gitlitz. I am a medical oncologist, and I left my academic practice at University of Southern California, although I still go to a half-day clinic there, to join Genentech, to learn about the real drug development process and try to bring some treatments to earlier stages of lung cancer. A lot of the developments that we are talking about are all in late stages of lung cancer, so we'll see how that goes. And I'm a huge fan of Bonnie Adario and her daughters and the family, a huge fan of Dr. Gandara, and a huge fan of patient advocacy. And we just came from Genentech for a session where there are many patient advocacy organizations there to, really try to get the patient voice into clinical trials, try to get more inclusion into clinical trials and more inclusion into screening for lung cancer and breast cancer. So just very happy to be here with all of you.
If we have time toward the end, I will tell you all how Barbara beat me in a debate.
I know which one you're talking about. I know which one you're talking about.
And she used underhanded tactics, so I'll tell you later.
If we forget someone, please remind us because we will make time.
I
for
know
that
exactly
story.
what that one is. Yeah. That's awesome.
Hi, Esty.
Yeah. Esty, you've been with us since the beginning.
Yeah.
You've been with us since the beginning. Yes.
Yeah.
Yes. But, Esty is a perfect example. She had lung cancer, X amount of time. And because of surveillance, which I highly recommend for a lung cancer patient, honestly, forever, because Esty was a survivor for a really long time. And then up pops a little spot. She had some radiation.
I did have.
She had some ground glass.
Yeah, ground glass about 3 years ago. I have a few of them. I still have some.
Yeah.
And Stanford suggested that they didn't like this one. It wasn't big enough to biopsy, but it wasn't. So they used the linear accelerator.
Yeah.
And quite a job.
Right.
Yeah. And they were able to just kill it.
Yeah.
About 3 years ago. So it's very hopeful for everybody.
Exactly.
Yeah.
And it's like a form of chronically managed.
Because I had surgery in 2003.
Right.
So what is that?
Long time ago.
17
We're not
years?
talking.
8?
Right. Wow.
But I was stage 1.
Yeah.
Found by accident. Because my daughter died of it.
Mm-hmm.
So all I did is insist on an X-ray, and my doctor said, I gave you a physical 2 weeks ago. I listened to your lungs. Tell me what your symptoms are. I said 0, and I want an X-ray. 0,
Great.
but I want an X-ray.
Yes.
She said, you have to have symptoms. Why would we give you I listened to your lungs. You don't cough. Nothing wrong with you. I said, that's fine, but you give me an X-ray.
Yeah, that's right.
Can I interject?
Please.
That's right.
So this is an incredibly important point.
Because my daughter was dying of it. She hadn't had an X-ray in 18 years.
Yeah.
And they treated her in Golden, Colorado for colds, flus, and allergies. And she kept on calling me, I have these allergies. I'm coughing. And then she was in stage 4.
Yeah. David?
So I don't need to say too much more, but I wanted to emphasize the point that lung cancer is one of the types of cancer where symptoms come very late. And this is part of our education mission to other physicians and also to patients. You probably have seen, I've seen lots of advertisements recently about the symptoms of lung cancer typically mean you have stage 3 or stage 4. That's the reason we need screening procedures. We're trying to develop blood tests to help the CT scans. And also later I'll talk about new tests to be able to determine prognosis. In other words, how bad or good is the cancer after surgery? And I'll come back to that.
Great.
That's great.
Okay. Awesome.
So that was great.
Thank you. Esty, your story is very important.
Hi, my name is Doug Ross. This is my first time here. I'm the acting chief medical officer for a company called Oncocyte that's developing tools for helping to manage and detect lung cancer. I've been working for the last 25 years or so in the genomics and genetics space, developing new ways of classifying cancer and then with companies trying to get them to patients. So it's been 25 years now.
Yeah.
Hi, my name's Robert. I was diagnosed in May of 2014 with stage 4 non-small cell. And I'd like to say that a week or so ago, my doctor said my latest scan it was the clinical remission, or NED, I believe the term. So I'm very encouraged to see the other guys here and gals looking at 10-year survivals and such as that. So it gives me a lot of hope.
That's awesome.
Thanks, Barbara.
And thank you to your lovely wife for taking such good care of you.
That's
right.
Good evening. My name is Keith. This is my second living room. I was diagnosed almost exactly a year ago with stage 2B squamous non-small cell lung cancer. Never smoked, but oh well. I had a full left pneumonectomy and followed that with chemo. And now I'm on a clinical trial of nivolumab, looking at post-treatment success with immunotherapy. And I'm sorry I missed the walk. A couple
Well,
weeks.
we're not going to forget it, but go ahead.
No, but hang on. But my wife said to me, we have to go do something big. So we did a 40-mile bike ride.
Wow.
So things are looking good.
Oh, wow. That's awesome.
Actually, I think what I said was, let's do something preposterous.
Right, exactly.
40 miles
And that is
different than a 5K,
preposterous. That's
yeah.
ridiculous.
And it was awesome. I'm Heather. I'm with him.
It ends with an OUS, whatever it is.
I'm Joann. I was diagnosed in September of 2016 after a full year of misdiagnosis of a cough. I was diagnosed with stage 4 adenocarcinoma, non-small cell EGFR exon 19 deletion. I think we got it.
There you go.
I had a 5-centimeter tumor in the middle lobe of my right lung, a small lesion on one adrenal gland, and scattered significant bone mets. I was put immediately on Tarceva, which worked for 2 years. And at about the end of that time, I became part of a research project at Natera to detect cancer progression through blood tests. And the test is called Signatera, and that showed, just at the end of the 2 years on Tarceva, a spike in my circulating tumor DNA. The Guardant test follow-up on that showed that it was T790M. So I went on Tagrisso, and that was a year ago. And it just coincidentally coincided when Tagrisso was approved first line. So, but we weren't moving to Tagrisso unless it was had other indications. Anyway, I had the other indications. So I have been on Tagrisso for a year, still participating in the research study, which actually now has gone commercial. And so every 3 months I have the circulating DNA analysis. And so far it has been 0 since it dropped to 0 after the first month of Tagrisso.
And they go to your house to take the blood draw.
Yes,
correct?
they send a mobile phlebotomist.
Yeah.
So, and I have had probably at least one scan in that time too. My oncologist, I guess her, what do they call it, standard of care, whatever, is that you do scans every 6 months, and that used to frustrate me, and I would talk her into 4 months or 5 months. Now I'm fine with 6 months, as long as the blood test still
got the other
shows
thing in
the zero circulating tumor DNA.
Yeah. Awesome.
Well, I'm Joanne's husband, and she's my caregiver.
I also want to double, triple what Larry said about being knowledgeable and the living room being responsible for that. And both at Natera and with my oncologists, they almost talk to me like I'm an oncologist, because they know I know the jargon, and I had to ask these questions, and they better know what I'm talking about.
That's right. That's right. When you're finished with Dr. Gandara tonight, you'll have more for him later.
Hi, my name is Shane Hart, and when my son was 3 years old, he was diagnosed with a very aggressive brain tumor. And anyway, he had 2 surgeries, and he went through a lot of chemo, but he's graduating from college this December, so he's doing great. And I'm a friend of Michelle's, and we were talking about it, and she asked if I wanted to come and see what's going on, and here I am. So thank you for having me.
Great.
That's great. Welcome.
Spread the word.
My name is Arohi, and I'm from Genentech. I support Tecentriq, which is an anti-PD-L1 immunotherapy. I've previously supported Tarceva, which some of you mentioned. Very humbled and grateful to be here, hear your experiences, and learn from you all. Thank you.
Hi, I'm Mike Jones. I work with Rohi, and longtime viewer, first-time visitor, and I'm very happy to be here, and thank you for having me.
My name is Fred Palmer, and I was diagnosed with non-small cell lung cancer in October of 2013. My most recent treatment was immunotherapy, which ended in September of 2018. I've been off any treatment since, and everything is very stable.
Thanks, Fred.
I'm also involved in the study that was described with the company Natera.
Thanks, Fred.
Hi, I'm Rebecca, and I was also diagnosed with stage 4 lung cancer. My husband usually talks a little bit. And it's been a couple years. Went through some roller coasters and some recent ones too, but I'm doing good.
Hi, I'm Wayne. I'm the caretaker. I want to thank Danielle for helping us get introduced to Dr. Gandara. We went on after she had progressed mildly on the carbo Alimta Avastin combo, we decided to participate in one of the trials, which, by the way, she's a KRAS G12D, PD-L1 negative non-smoker. So he introduced us to a KRAS trial, and we were really grateful and had some high hopes for it, but it didn't work out. The trial involved IO drug called, like Keytruda, along with trametinib. She went through 2 cycles of the trametinib and 1 cycle of the Keytruda until she got hospitalized with really bad mouth sores. She couldn't eat, drink, or swallow. We were really hopeful because her cough had just gone away, so we thought it was working, but the scan, we thought it was working, but the scan ended up showing that she actually developed 5 new brain mets in that 2 months. So we've moved off of that, and we're on gemcitabine, and we're going to try to, get some stability and try to regroup and figure out what to do next.
So we need to talk.
Yeah. Thanks, Wayne.
Hi, I'm Richard, and I'm nervous. Anyway, I'm the caregiver for this little fighter. She started in 2005 with non-Hodgkin's lymphoma and had Rituxan, which was one of the first targeted drugs for cancer in Genentech. In 2016, in March, before that, in November, she was kind of coughing a lot, and we all thought that she had allergies, and, they never took an x-ray. And so, 4 months later, they found out that she has stage 4 non-small cell lung cancer. She's EGFR T790. She's been on Tarceva for 12 months. Then she was on Tagrisso for 12 months. Now she's still on Tagrisso, but she was taking carboplatin. It goes on and on.
So when I progressed on Tagrisso, they took away the Tagrisso and they added carbo Alimta, and I flared. I ended up in the hospital with lung inflammation. At the time, I had a second opinion from Dr. Blakely, and he mentioned, oh, well, let's put you back on Tagrisso. So he talked to my oncologist, and they agreed that would be a good idea. So they put me back on Tagrisso, gave me carbo Alimta, and the only side effect was low platelets. So sometimes I wouldn't have the carbo for at least 4 to 6 weeks between cycles. And then I was on Alimta maintenance for about a year. Then they put me on docetaxel. Docetaxel was really bad. I was in and out of the hospital 6 times. 6 times because of pleural effusion. They put a catheter in. The catheter had an infection. It came out. So now I'm on Abraxane. Abraxane is still part of the taxane family. I was a little concerned that because it was in the taxane family, I would have the reaction, but I didn't have.
So far, so good.
So far, so good. So what's going on with me now today, I had chemo, and we decided to come in because I've been offered an opportunity to have my lung airway. There's a tumor on my lung airway, and it's affecting my breathing. So the radiologist offered to give me radiation to reduce the tumor so that I can breathe better. But, it has side effects. Side effects like my esophagus can get inflamed. It would be hard to swallow. And the other side effect was possible, I can't remember the name of it. Anyway, I'm...
So she's one of the first, on Tagrisso and chemo, and then there's some debate, with her, she doesn't have PD-1, is there something else? Is there, the immunotherapy maybe doesn't work, or maybe it does, or all this good stuff. So we'd like to talk to you sometime after.
You bet.
Thanks, guys.
Yep.
Evangeline, you're up.
Hello, good evening. My name is Evangeline, and I was diagnosed non-small cell lung cancer, adenocarcinoma on March of 2017, and then I had cyberknife radiation. No, I was diagnosed March of 2017, and then I had cyberknife radiation May of 2017 because I had it metastasized on my right brain, and I have another tumor on the left bone of my skull. And then I started on Tarceva 5 days later after the cyberknife radiation until March of this year, and then my medical oncologist switched me to Tagrisso, April. After 3 months, I had MRI and CAT scan, and the Tagrisso worked. All the tumors shrunk. The tumor on my left lobe of the lung shrunk by 1 centimeter, and then on my brain it's unmeasurable. So I just had my MRI October 3 and a CAT scan October 4, and I'll know the result this Friday. I will be meeting with my cyberknife radiation oncologist and as well as Dr. Neil, my medical oncologist, this Friday. So I'm hoping for the best. Thank you.
Thanks, Evangeline.
Pat Pritchard. 11 months ago, I was incidentally found to have 2 tumors, one on the left, one on the right, and they're different. One is BRAF positive and the other BRAF negative, and I don't know what that means, and nobody else seems to have the same thing. So I feel like the Lone Ranger. But I am very lucky, very blessed to be stage 1. So I'm going to stay here, keep scanning and fighting. And thank you all for being so inspirational.
Thanks, Pat.
I'm Candy Hernandez. I'm here to support my friend Evangeline. We both have cancer, but mine is different. I had my cancer was healed for like 3 months, and then it came back. I used to come here. I used to cover my hair, remember? I was bald. Now my hair grew, and this is what God gave me. But I'm so proud of it. But I'm here to support Evangeline. We support each other, and we belong to the same church together.
You're like Tim and Don.
Yeah, that's awesome.
Buddies.
Hi, my name's Betty, and Betty Corner, and I was diagnosed in 2014, And it went from stage 1 to stage 4 to oligometastasis, which means I had a couple of brain mets, but no lymph node involvement. I was lucky enough to find my way here and listen to everybody here and talk to Dr. Carbon about what is oligometastasis? What the heck is that? You know, I had a lymph first with carboplatin, and then we were able to find out I was EGFR positive, exon 21, and I was on Tarceva. Then I did well enough that they removed my right lower lobe and 19 lymph nodes just to make sure, and a little bit of my right upper lobe as well, and did CyberKnife on my brain, and I've been doing well ever since. I had a PET scan yesterday and it was all good, so I'm happy to be here.
Thanks, Betty. I don't think I missed anyone sneaking in, did I, Bridget, that maybe sat someplace else?
Sally.
No, Sally passed. Sally didn't want to tell her story. Sally doesn't want to tell her story. So what I'm going to do before we open up and do the last hour and change, educating everyone on tonight's topic, I'm going to ask Dr. Gandara to tell us a little bit about himself. As you guys know, I used to spend a lot of time like this and a piece of paper reading our amazing speakers' bios and whatnot. And it just didn't seem very personal to me. So about a year and a half ago or so, we started just asking our speakers to introduce themselves. Tell us, you know, why they're here, why lung cancer matters to you, why you chose lung cancer as your sort of spot to lay your head and do your good work. So you want to give us a little bit
And then
of
I'll
that?
add whatever he forgets.
Yeah.
I think I'd like to start by saying the reason that I'm a lung cancer oncologist is because of this room. I mean, it's incredibly inspiring, and not just to me, but I'm sure to all the other speakers that come here, to hear these stories. I could speak for 3 days just based on your stories. But I grew up in Texas. I went to the University of Texas in Austin, and then medical school in the University of Texas Medical Branch in Galveston. And then I came to the West Coast, and I'm still here. And met my wife here, and I've been at UC Davis. She's a 4th generation Northern California
And an angel.
girl. She is.
Yeah.
Some would say she's an angel to put up with me.
That's
but,
right. That's what I was referring to.
But I've been at UC Davis for 25 years. I was in the military. As a medical officer, did my training at Letterman Hospital on the Presidio, which is now a national park, you may know. But at the time I did my training there, it was the biggest hospital, biggest training center in Northern California. We had more fellows, more oncologists, hematologists than Stanford or UCSF. So it was quite the place in its day. And then after that, I went to UC Davis, where I still am. So I was for 20 years the Associate Director of Clinical Research. So everything that had to do with patients. And I helped take UC Davis from a brand new cancer center to what's called an NCI designated cancer center, to an NCI designated comprehensive cancer center, and the fastest trajectory in the history of the National Cancer Institute. So we're very proud of that. I've since given up that role to, many of you know Karen Kelly, who's with me at UC Davis. She's now in that role. But I remain the Director of Thoracic Oncology. I have a brand new 6-year grant from the National Cancer Institute for $3 million to develop new treatments. So I don't plan on going anywhere anytime soon. But my passion is teaching. So I speak at many meetings around the world. Actually, tomorrow I fly off to Mexico City for the same meeting. We're unique in lung cancer in that we have an organization called the IASLC, our International Association for the Study of Lung Cancer. It's 50 years old, and there's nothing like it in any other cancer type. From day one, it has been what we call multidisciplinary, meaning it's medical oncologists, plus surgeons, plus radiation, plus pathology, plus pulmonary, everyone that would be involved in the diagnosis and treatment of lung cancer. And it's international, which again is totally unique. So this meeting we're going off to is the Latin American specialty part of that meeting. I love to teach. I think this is probably my, maybe 5th time over the years. How long have you been doing the living room?
You've come way more than
10 years. We've been doing the living room for almost 10 years.
Well,
you come at least once a year.
Yeah.
All right. So at any rate, I love coming here, and I always tell everyone that education is bi-directional. And it doesn't matter whether you're speaking to a medical student or a fellow in hematology oncology or to patients and their caregivers. I learn as much as you learn from me. Bonnie and Danielle know that I pride myself on being able to communicate what are usually complicated techniques, factors, information about cancer in a way that patients can understand it. And so that's been one of the things that I've prided myself on. And I'll share some of those with you today. How many of you are on Twitter? Anybody? Okay.
Yeah.
How many of you saw my tweet about coming to the living room? Did you see it?
I didn't see it.
Because,
You got an email.
and I'll just do this very briefly. I said, you know, I'm going tonight to my favorite place, the living room. I'm going to be talking about communicating personalized medicine to patients, patient advocates, and of course, everyone that will view this, either live, webcast, or archived. You probably know this goes to over 100 countries. And I said, for example, I said, molecular fingerprinting is a way to communicate with patients about molecular testing. Everybody knows that their fingerprint is different from everybody else's. Your molecular fingerprint is like that. It's the ability for us to separate your cancer from your cancer from your cancer. And then I said, I also talk about drivers. What's driving your cancer, which again is different for most of the people around the room. And then backseat drivers. And that means that we're finding out, somebody mentioned that they have the exon 21 EGFR mutation. That one in particular has some backseat drivers that try to tell the driver where to go. So anyway, these are just examples of this way of talking in analogies. So anyway, that's my story.
Yeah, no, I think it's fantastic. And one of, as Dr. Gandara already mentioned, one of the things we love many things about him, but his ability to explain things and use analogies like your drivers and your backseat drivers that actually make sense in this complicated space, right? And I will tell you that Bonnie reuses your analogies over and over and over.
I don't give you credit for it.
She doesn't. No, I'm teasing. She does.
No, I
She
do.
does. She
I'm
does.
kidding. I'm kidding.
So,
But,
go ahead.
But what he didn't tell you is there is no doubt in my mind he is one of the top 5 oncologists in the world. Not just in the Bay Area, in the world.
I may just keel over.
Yeah.
You are in the presence. You are in the presence tonight of royalty. So if you have a question to ask it, be brutal, and he will be
Don't be
just as
too brutal.
back. Right? Right?
Yeah.
Well, yeah, he is.
Let me tell you a real quick funny about attribution, about things that you do. I was at a recent meeting where a very highly respected oncologist was talking to young oncologists about how to have a successful career. And I all of a sudden saw my slides there from about 10 years ago where I had used the David Letterman show. And you know how he had the top 10?
Yeah.
And I said, here are the top 10, starting with number 10, going to number 1, about how to become successful. And he was giving this, and he said, I don't know why David Letterman would have ever given advice to oncologists, but I found this, and it's fantastic. And he said, and so I'm using it in my talk. So I didn't say anything. And then after his lecture was over, I said, you know, those are mine. He said, I found it on the internet, and somebody had removed my title slide and plunked it on the internet. So now I try to put my name at the bottom.
Exactly.
Yeah.
Always put your name
Embed it on the slide.
Right,
Yeah.
right,
That's
right.
great. That's great.
Yeah.
So before we jump into the topic, I just want to make sure that nobody online had anything to say, hello, hi, or otherwise. They're just all.
All right,
good.
let me just give you my number 10. Maybe I'll come.
Oh, there we go.
My number 10 was if all you have is lemons, make lemonade.
Yep.
So one of the speakers here before, David Carbone,
Yes.
who's spoken here.
Yes, yes.
He had a trial which was totally negative. It was for immunotherapy, and in this trial, immunotherapy didn't beat chemotherapy. He got it published in the New England Journal, which is probably the most prestigious journal. And so I used it as an analogy for the young oncologist because I say David Carbone made lemonade. He found a marker within the tumor in these patients called TMB, or tumor mutational burden, which showed if you looked at the patients with high tumor mutational burden, they did much better on the immunotherapy. So he made lemonade, got him in the New England Journal.
Exactly.
And it was one of the first examples. Now we have 100 publications on this biomarker. He started it by making lemonade.
Exactly. That's a great story, David.
And I think it's so important, and I think when we're looking at research and how important it is, and you guys know we talk about it all the time, we're going to talk a little bit about where research has brought us today and maybe where it's going to take us in the future. But where I want to start, we've given, Dr. Gandara's done a great job talking a little bit about personalized medicine and what does that mean, and about molecular fingerprint and how nobody's cancer is the same as the person sitting next to them or the person across the room. So I think it's sort of apropos to open this conversation with the molecular testing component or biomarker testing or whatever, genomic profiling or one of the many things that it's continually called. What does that mean? What does that look like? Specifically those 8 oncogenes and what beyond that?
Right. So I think the introduction for this topic would be to say that 10 years ago or 20 years ago, we had research. And then it took years and years before that research came into clinical practice. These days, that has been turned on its head. And what was research yesterday is clinical practice today. And that's where we are for molecular testing in cancer, and in particular for lung cancer, non-small cell lung cancer specifically. We know that it's an incredibly complex cancer in terms of mutations. So that molecular fingerprint is more complicated than most other cancers. We started out knowing that one of these mutations, and it was the EGFR, which quite a few of you have, could predict who benefits most from drugs against that target, against EGFR. So one thing I'll have to say is almost everyone in this room use brand names. I can't use brand names. I have to give the generic names. So you may not know what the drugs are when I talk about them, but you can look on Google and it will tell you. So those initial drugs, gefitinib and erlotinib, changed the life of cancer patients around the world that had that kind of mutation. And now we have not even second generation, but what we call third generation agents, like osimertinib, otherwise known as
Tagrisso, some of you said it earlier.
But anyway, that's where we started. And the point Danielle is making is that now, today, in 2019, we have 8 of these markers that will predict who will benefit most from that drug against that target. And you heard about one of these earlier, the Loxo drug, which is against one of these called RET. highly active, and we have just many examples of this. What that means is if you have non-small cell lung cancer advanced stage, typically stage 4, and especially if it's an adenocarcinoma, in 2019, your cancer needs to be tested for all of these 8. I saw a patient this past week, otherwise very, very good oncologist, and she said, well, we had to do such and such because the patient didn't have EGFR, they didn't have ALK, and they didn't have ROS1 in their cancer. And so my response, in part, was, what about the rest of them? And the reason I said that in this patient is she is a never smoker. That should set off a bell that this patient is highly likely to have one of the 8 oncogenes because they're more common in never smokers. So that's one of the things that I did when I saw her last week, is realizing that she needs new treatment right away. And even if there was residual tissue, it would take some time to do the testing. I drew blood on her to send it off for a panel that within 7 days will give us the results. And I'll just mention the name. It's Guardant, the Guardant blood test. And again, Barbara will appreciate this. Their turnaround time is 7 days. That's 7 total days. Every other test tells you about working days. In other words, they don't count the weekend. You could be in Singapore,
right,
or you could be in Abu Dhabi. You will get this test back in an average time of 7 days. So in 7 days, we'll know about the rest of these oncogenes in this patient. So that's,
So,
yeah.
so we've talked about the 8 and sort of what, when I talk to patients, I talk to them about like just sort of this baseline lung specific testing versus like a comprehensive test. What are the benefits to, like at minimum, these patients should be getting tested for the 8, right? But what about and when does it make sense to do a more comprehensive testing?
Right. So this is debatable. I should mention actually though that we're about to have number 9, G12C KRAS mutation. Because of some
30%
new
of lung
drugs like
cancer.
absolutely hot off the press.
Yeah.
Hot off the press within the last month.
Yeah.
So it's going to be number 9. I can almost guarantee you that.
Huge.
So the issue about testing is that 15 years ago, when EGFR was discovered, we tested just for EGFR. Or some people said, well, test for KRAS because we already have that test around. Even though we didn't have anything to do for KRAS, they said, if the tumor is KRAS positive, it's not going to be EGFR positive and you don't have to do any more. That was wrong. But in the meantime, all of these other abnormalities, which we've heard about, some of them in the room today, ALK and so forth, they all came about. So in 2019, some oncologists or pathologists who direct the laboratory design for the testing will test for one, then test for the next, then test for the next. That takes forever. So what you want to do is test for all of them at the same time. So there are other platforms that we call sequential, right? You test for one, then the next, the next. There are exclusion tests that will test for 5 or 6, but don't test for all of them, and also don't allow you to assess other abnormalities such as the tumor mutation burden. And then there's what we would call next generation sequencing, where literally hundreds of genes are tested. And that gives you all the 8, plus a lot of other things, which some of them are meaningful, some of them are not, but you need them to give other information such as the TMB. I know this is complicated, but what this means is in 2019, if you can get next generation sequencing done on your cancer, that's what you should do. There was a really nice recent study looking at comparative effectiveness or cost effectiveness of these various ways, sequential, exclusion, next generation sequencing. And Dr. Pinnell here in the United States, Cleveland Clinic, showed in a modeling study that you actually save money by doing the next generation sequencing because you test for all of them at the same time. One test, boom, you've got the information. And then, as we'll come to in a minute, we can now do exactly the same thing in blood. Blood and tissue are a little different. Again, that's complicated, but we're about to do a new consensus paper for our ISLC where we're going to say blood is now moving up front. And maybe you don't need to do tissue first, maybe you can do blood.
So I have a question, and I just thought about it as you were talking, and we've had these conversations at the living room before and obviously in other places. When we're talking about next generation sequencing, and I'll use another block, so like let's use NTRK. It's a pretty small percentage of the population, right?
So she's getting way out there. We're like circling Pluto.
Yeah, but here's where my question's gonna lie, because I'm trying to think of patient benefit from a research benefit, I guess, from what we know about the patient. Like, had Loxo had information on patients who had NTRK and could have filled their trials quicker, could we have gotten drug to patient faster? Do you know what I'm saying? Like, if we had this genomic profile.
So the answer is yes.
Okay, thank you.
How many of you have heard about the Lung Master Protocol or Lung Map? Have you heard about it? Some people have. Okay. So we developed this. Actually, my colleagues in crime, I guess I should say, Roy Herbst and Papa Dmitry Piccolo.
Yeah.
And won an award from the Addario Foundation on team science. Because we got together with the National Cancer Institute, with the foundation of the NIH, with 20 pharmaceutical companies, with Foundation Medicine, which has a testing platform for molecular testing, and with the FDA to form this master protocol where if you're a patient that gets entered into it, we will test thousands of patients per year, thousands. We have 500 sites in the United States. And we will place the patient, as the studies are available, into a trial where you get a drug against your mutation. And if you don't match, we have several immunotherapy trials where we match you with what seems to be best for your cancer with immunotherapy. So both the genomic and the immunotherapy. So if there's a rare abnormality, an NTRK, a RET, then if we're testing thousands of patients a year in 500 sites, we will find the 2%ers. We'll find plenty of them to do the trials and show that the drug is either active or not, because part of our mission is also to rule out drugs that sound good. Maybe they work in breast cancer, or they work in hematologic malignancies, or they work in bladder cancer. And I use those three examples because there are drugs out there for those three cancers, same mutation. In lung cancer, they don't work. So we're about to initiate a confirmation trial for the FDA with the Loxo drug in RET-altered cancers. So we can do that faster than any company could do it because we're testing all of these patients. The very same is true for TRK, and we're going to have a TRK study as well.
Yeah. I'm honored to say that when Lung Map materialized via SWOG, Southwest Oncology Group.
Where Bonnie was our patient advocate.
I was, and I got to contribute a lot to that, and it was a great learning experience for me as well.
But I think, I guess
such an amazing.
The takeaway here is that this molecular testing, genomic profiling, biomarker testing, whatever you want to call it, is important for so many more reasons, right? The obvious, you would like to find a target where there is an approved drug for your cancer. However, if you don't, and Rebecca's a perfect example of that with her KRAS and whatever might be going on, right? That if it's not available now, maybe it's available down the pike, and it's good information to have in your back pocket for if and when this ever comes to fruition.
If I can just add one more.
Please.
So, I forgot what I was going to say.
Oh, I know that. problem. I got it myself.
I know that problem.
Where was
Oh, I know what I was going to say. So when I said Lung Map is available in 500 institutions, almost all the institutions in the Bay Area have it active. Kaiser has it active.
Yep.
You know, Sutter, Dignity, most of the sites have Lung Map active. So I realize it may not be for all of you, you know, but it could be for some of you.
Yeah.
So keep it in mind.
Yep, I
Because
think
if
we have a
you're on
question in the
one
back. We
arm-
just need a mic.
If you're on one arm of the Lung Map trial and it's not working for you, you have the option of moving to another arm
We'll
in
get
the
it.
trial without starting all over again in another trial.
Thank you. I lost Bridget. She's my mic roomer.
Oh.
Oh, jeez.
I was wondering if you could tell me a little bit about the washout period for the lung map.
Typically, it's about 2 weeks. It depends on what the previous drug was.
Can you
2
explain really quick what
Yeah,
washout
I'm
is
sorry.
for those who...
I should have.
That's okay.
See, this is why Danielle, she's
Just like,
knows this
let's
stuff.
explain what it is.
So typically, when you're going to try a new treatment, especially when it's considered investigational, we want to have the previous drug out of your system, because otherwise, if you have a bad side effect or something else happen, it may not be the new drug, it may be left over from the old drug, or it may be the old drug still in your system that shouldn't have been given with the new drug. So we try to minimize that amount of time as much as we can, but it is a safety issue. So there's always some minimal washout period.
It's such a catch-22 for patients because it's a terrifying moment, right? You're going to take me off. Yeah.
I'll just throw in, there's one thing too, and I know some of you may say, you know, I don't agree with this. It is rare that lung cancer treatment is an emergency. Sometimes when a patient shows up first time, it is an emergency. But that is typically maybe 5% of all the lung cancer cases. It's pretty rare. We have time to test your cancer. We have time to do the appropriate diagnostic studies, get the MRI of the brain, all of these various things. And my concern is that sometimes oncologists are so fixated with getting you on treatment right away, because it's good for them too. That way they decide, they put you on the treatment, that they don't do everything. And this is particularly true for the molecular testing. We're having a real problem in the United States now, some of you are aware of this, where patients are getting put on chemotherapy plus immunotherapy before they ever get molecular testing. That's bad, and we're seeing the results of that. So that's just my little editorial, but I want to assure all of you who have cancer or you're a caregiver that are in this room or who are on the webcast that ask, do I really need to have this new, somebody used the word empiric earlier, treatment, or do we have enough time to do testing to figure out what's going on? And a perfect example of this is ALK, where there's the empiric approach or there's the reassessment approach. Maybe we can come back to that later.
Yeah, I think Rick actually has a question, so.
So two things, because of this subject you were just talking about. There's a person on our ALK site that was diagnosed with lung cancer, and before getting any test results or anything, was put on traditional chemo and whole brain radiation, which is a pretty aggressive start with not knowing what you're going after. And as it turns out, when they got the testing back that he was ALK, they went on meds, and 3 months later was NED, but it really had nothing to do with the regular traditional chemo or the whole brain radiation, which causes other issues. So that was upsetting.
Do you want to just take my place up here?
Yeah.
Because
So that was very
you're
upsetting
saying
to hear.
everything I was going to say.
But the next thing that
Well, can we
pertains
just
to
deal
me-
with that one first?
Yes, go.
Okay. So this is a great example, and we see this all the time, where some of the new treatments are so effective, it means we don't need to do other things. We don't need to give whole brain radiation. And this ALK-positive cancer is a great example of that. And the greatest advocates at our place at UC Davis for trying the drug, the TKI, against ALK or EGFR, instead of giving radiation, or our radiation oncologists, they bring those cases to us and they say, you know, Mrs. Jones was referred to us from outside for whole brain radiation or even stereotactic radiation to the brain. She's got an ALK-positive cancer. You know, don't you think we should give her a trial of one of those drugs? And the answer is yes. We'll monitor her carefully, make sure she doesn't have any symptoms, because if she had emergency symptoms, then yes, you give the radiation. But again, most people will not. So that's a perfect example of this. The second, and I just want to remind you all of this, because patients, this is a little bit of self-guilt. You know, when you said I'm an ALK-positive patient, you're not an ALK-positive patient. You're a patient with an ALK-positive cancer. The mutation is in your cancer. It is not in you, with the rare exception of people who have certain, what we call germline abnormality that is hereditary through their family. But I think that's important for patients to emphasize. I'm not mutated. It's my cancer that's mutated. That's your target.
Right.
Yeah.
And on the second note, so we've tried to do genetic testing on me. When I was first diagnosed, it was back in 2014, and they did, I guess, a FISH test is what was available at the time, and that's what came up.
Fluorescence in situ hybridization, that's a mouthful.
FISH was so easier.
And fish is, we don't use fish as much now. We say it's bad fish.
Right. So they took a tissue sample. We had no treatment of any kind until we got the results. I was ALK positive, so I went on crizotinib. Crizotinib worked great in the body. Wiped it didn't make things disappear, but it stopped all the metabolic rates. So basically it became like scar tissue or something, whatever, it stopped. But about 18 months later, had brain mets. So I had the option to go to a trial drug, X396. So I went on that for 2.5 years. During that time, we still had slight progression from time to time, but all very small and not affecting my life, and quality of life was awesome, so we never made any changes. Then I switched over to alectinib, which didn't work for me at all. I had all kinds of side effects, but also was having more progression. We've tried blood biopsies twice, but because nothing's active in the body and it's only active in the brain, they came up with blanks. So then they even decided to do a trial spinal tap, see if they could get something from the spinal fluid. Again, came up blank. So now I'm on brigatinib, where the side effects are much better. I had a scan, things seem relatively stable. So you kind of assume that it's still ALK and, you know, there hasn't mutated or really around it in another way. But without being able to do any testing, because you can't get the tissue, it's extremely frustrating from my perspective, particularly listening to this subject where testing is so important, which I agree, but just no way to get it. Do you have any suggestions?
I think your case is absolutely a small minority, fortunately. And I agree with everything that your oncologist has done, including trying to get the CSF, the cerebrospinal fluid. But ordinarily, and what I'm saying is 98% of the time, there will either be tissue or blood will show something. The exception to that, those other few percent, typically is in the brain, where the cancer is active in the brain, but it's not active in the rest of the body, so there's nothing to biopsy, and because there's nothing in the body that's active, that mutation or translocation isn't being shed into the blood, so you don't pick it up in the blood. So that's a difficult situation. But in general, and again, I think ALK is a great example of this, there's a lot of debate now about whether we pick the next drug that we think is the best drug as oncologists, or whether we rebiopsy or get blood and see what's in that cancer today that wasn't there before, and base the new treatment on what you find. There's a very famous slide, and I'm sure everybody who works in oncology will know what I'm talking about, that's kind of like a heat map, red, green, and yellow, that says if you have an ALK-positive cancer and you've had crizotinib, and now you have progressive disease, what's the likelihood of a certain mutation coming out? And out of these new drugs, lorlatinib, alectinib, brigatinib, is that mutation sensitive to those drugs? And then pick the one against your mutation if you have a mutation. If you don't have a mutation and you have what's called the backseat driver has taken over, the bypass mechanism, then maybe another ALK agent isn't in your best interest, and you should have a different treatment instead.
Yeah.
All of this is still, like I said, in transition. Research, moving into clinical application. But probably within the next couple of years, we will know all of this. There's a National Cancer Institute ALK master protocol. So when I talk to you about our master protocol, now there's a new master protocol just for ALK-positive disease.
I love your analogy when you talk about just what you're talking about now, about who's driving the bus. And when that bus driver gets off the bus, a new driver gets on the bus. And we have to always know who's driving the bus or what's driving the bus.
Who's the bad actor?
See, I don't even need to come. They could just prop up a little cardboard here, and the rest of you could give this talk.
And that's the beauty of genomic profiling. You know, you just keep that testing going, and if that's not happening, because mutations can mutate.
So one of
Do you have any suggestions how to get testing in my situation? Do you have any suggestions on how to get testing? How to get a result?
Eventually, it's going to show up in the blood. So some oncologists will say, well, I tested your blood and it's negative. But particularly if anything changes in your clinical condition, I would get a repeat blood specimen. Obviously, if there's something that grows that could be biopsied, that would be just as good or better. But I'm just saying, right now, I think your oncologist has done everything possible. And if you're tolerating brigatinib well and you seem to be benefiting it, that's what I'd stick with.
Yeah.
Don?
I just had a couple questions on the lung map. And you had mentioned...
Don's about to go on lung map, I think, so.
Yeah, that's some of the questions.
And he wants a commitment tonight.
You had mentioned a 2-week washout with systemic treatment. Is that the same for CyberKnife, or is that longer?
There is, you've got me on that one. The protocol is only 242 pages long. So
That's all.
I don't know the answer to that, but I'll tell you our coordinators do.
Okay.
It may be very short.
Okay. I think the coordinator is looking into it for me. So the other thing is Kaiser does...
The other thing is an oncologist always should admit when they don't know the answer.
Thank you.
You know what I'm saying? Just, sometimes you know, sometimes you don't.
Yep.
And the other question, I know Kaiser does offer lung map, but 2 months ago when I looked into it, my oncologist said they're only offering one arm of lung map. And I know you were instrumental in approving SB 37 or getting it approved, the Senate bill, where if you're on Medicare, they have to allow you to take the trial anywhere. And when I approached him, he said, no, take it at UC Davis. Because at the time, it was only one arm of the trial that Kaiser was offering. Although my radiation oncologist did mention she saw something come through her desk the other day that she thought they might be adding a couple arms or another arm of the trial.
Right. So this is a complicated answer, but lung map, because it's a master protocol, it has new sub-studies come on all the time. And it's got a brilliant design. I designed it. Which is that if one study closes and another is opening, it doesn't affect the entire machine. The entire machine keeps going. So in this case, in order to have lung map open, that institution has to have agreed to what's called a central IRB, which makes the informed consents. So that means that automatically, it is available when a new study opens because it's central IRB.
IRB is Internal Review
Yeah.
Board.
Oh, thank you.
You're welcome.
So Kaiser maybe hasn't put it through. They could. What I'm saying is it's part of the mechanism. And yes, we have several new studies opening, including 2 with patients who've had prior immunotherapy and now they have progressive disease, and what do we do then? And the Loxo drug that we talked about, and a couple of others. So we're also going to have the KRAS G12C drug in LungMap, but we have it available quicker than that through some other trials. I think so, but I don't know for sure.
How would I be able to tell if they have it?
I would ask them.
Yeah, we
But
can find out for you.
There's also a website, so you can look up and see who's got it open.
Yeah.
Yeah,
And the
we can-
Adario Foundation, or I should
Yeah.
say GoTo
Go-To.
Foundation.
Right,
We
it's
can,
okay.
we can help look and see if it's available there. Yeah.
I'm pretty sure they do, but I don't know for sure.
Yeah, I don't know.
Absolutely.
So I have a question. We've done a lot of talking about this, amazing talking about what's driving your cancer, this molecular testing, you know, biomarker testing. I keep using all of it just so everybody, in case you use a different word. What we haven't talked about is who we're testing. We've got a lot of adeno patients in the room. We have a squame patient in the room. I know we work with small cell adenosquame sort of mix and others. Who are
Small
we?
cell.
Who are? Yeah, I said small cell. Who are we testing?
Well, that's also undergoing evolution over the last few years. As a matter of fact, in 2013, when the first guidelines were put out, probably get myself in trouble for saying this, but when the first guidelines were put out, it said you only should test adenocarcinoma of the lung because squamous cell in particular doesn't have these mutations. We've since, and I objected to that even in 2013, I had 2 women in their 30s who had EGFR mutated lung cancer, and it was purely squamous cell.
Yeah.
Because some of the guidelines said, well, if your pathologist said it was squamous cell, they're a bad pathologist.
Yeah.
That's not true. And in China, where EGFR rates are really high, 20% of people with squamous cell lung cancer have an EGFR mutation in their cancer. So a lot of these things are changing. Right now, we would say all adenocarcinomas should be tested for the 8 oncogenes. Remember, because that's not being done. There's going to be a survey presented at the LAUCA meeting, which says it's only about 60% of oncologists that are doing that.
Yeah.
And a squamous cell patient, because we do see them, who's a never smoker, has a familial history, is young, has any other characteristics which seem atypical with the usual squamous cell cancer, they should be tested as well. Now, small cell lung cancer is a totally different malignancy. And right now, there is no specific oncogene where we would base therapy upon that. Not that we haven't tried. Barbara knows we've had 20 randomized trials in small cell within recent years that have not improved treatment outcome. We now have 2 that have.
Yeah.
But it's not with molecular drugs. It's with immunotherapy.
Yeah.
Adding immunotherapy to chemotherapy.
Exactly.
So sometimes, you know, you can't fit everything into one box and say molecular testing is going to fix everything. In this case, for small cell, it was immunotherapy that made an advance.
Barbara, in our genomics of young lung, didn't we had squamous patients? Yeah. Yeah. Yeah.
One of them did.
Right. Yeah. And that was 4 years
Barbara's
ago.
not holding her mic.
That's okay. We heard her. She said, yes,
We
we
heard
did.
her.
Yes, we did. Had a squame.
So the other thing is some, and I don't mean to badmouth oncologists, but some oncologists will say, well, you know, I've only ever seen one patient in my entire career who had what you're asking about. Well, for you, even if it's 1 in 100, if it's you, it's 100%.
Yeah.
So, you know, there's I think building consensus that these rare abnormalities, RET, MET, you know, all of these that are only 1 or 2%ers, if you have a test that can test for everything in one test, that's how you'll find the rare ones as well. and you will save a patient getting chemotherapy or sometimes immunotherapy when they shouldn't get it by testing for everything.
Yep.
This is why it's so important.
Test.
Yeah. So I'm going to try not to sound like the fool when I ask this question, but going back to small cell for just a second. You touched on immunotherapy, and I do want to dive into some immunotherapy conversation before the time's up. But there was a DL8?
DLL3.
DLL3, thank you.
Yes, don't he's our other
I know,
consultant.
he is. What's going on there?
So that's a long story.
Yeah.
But this is a drug that has a wonderful rationale for it. It's a specific inhibitor of this abnormality, which is very high expression in small cell lung cancer. And the early data seemed very positive. But that's the reason sometimes that we really need to do phase 3 trials, where we compare it to whatever's the standard of care. Because over and over again, we find out that early data from a small study may not play out the same way in a bigger trial. So I know patients don't want to be randomized. Most often now, patients are not randomized to only a placebo. It may be standard of care, which it could be chemotherapy, could be immunotherapy, could be a variety of things, plus a placebo versus the new drug plus the standard of care. But in this case, the drug didn't pan out well, and it ended up having a lot of side effects. So it's not probably totally gone yet, but it's what's called a drug-antibody conjugate. That means you have something that goes into the tumor because the tumor is positive for it, but you hitch on something that's a chemotherapy that once it's in the cell will get released and kill the cancer cell. And those linkers are very complicated to make. And part of the problem with this is the linker didn't make it go into the cancer cell completely. So the concept is totally valid. There are other drugs against this target still being developed now, but I'm not sure this drug's ever going to make it.
But this, I guess.
But you're right, it would have been the first targeted.
Yeah, and it kind of points back to the importance of this testing in all tumor types at some point on some level, right? Whether it's a non-small cell or a small cell, because without the testing, we wouldn't even know it was there.
That's true.
An initial testing.
Amy,
can I throw in one more thing?
Yes, no.
So the other thing is that patients often, and I get this all the time, patients come in, they've read, and they come in and say, Dr. Gandara, I just want to let you know, I don't want a phase 1 trial. I only want a phase 3, or I only want a phase 2 or 3. And I'll say, why? And they'll say, well, I heard that these phase 1 trials are always negative and you never get anywhere. Every one of these new drugs we've talked about tonight was highly active in phase 1. Phase 1 trials today are not your grandfather's phase 1 trials. And there have been several publications showing that even people who go on a phase 1 trial with cancer have a much better survival than patients who get treated with whatever was the next available thing that the oncologists could have used. So you should know everything about the trial. You should know the risks, you should know the benefits, but don't be scared if they say it's a phase 1 trial, if the rationale seems good, because it may be a home run for you.
Amy's got an online question.
Yeah, so we had a patient earlier who asked about EGFR that sometimes converts to small cell. Can you speak to that a little bit?
Right. So we're getting in advanced. So we started out with personalized therapy 101. We're now at the graduate school level. So this is totally bizarre. When I first heard this, I said this cannot be true. But there are some cases of patients with adenocarcinoma that's EGFR mutated that you treat with an EGFR drug, and at the time their cancer gets worse, it has converted into this otherwise totally different looking, different acting cancer that we call small cell. So it does happen. Some people would say it maybe happens 10% of time. I've personally never seen a case. My colleague Jonathan Reese, I asked him last week, I said, have you ever seen, no. Did you see cases in your practice?
ALK positive.
To small cell?
Mm-hmm.
So it can happen. That's one place where the rebiopsy is the best way to find it, because the blood markers are indirect. I have picked up some cases, other people's cases, not my own cases, where the patient had mutations in the blood which were associated with small cell and not associated with the EGFR. And those would be RB and P53. So sometimes you can get a good idea that it's small cell based on the blood, but you have to confirm it with a biopsy. So it's rare. If that happens, there is debate about, you treat it with the small cell chemotherapy, which is effective. Some people keep the EGFR on, some don't. And right now, I'm not sure that we have a clear-cut answer to what's the best approach.
In that case, do you think it's a mutation, or is it possible it's just two separate cancers and you're just unlucky?
Again, we're at graduate school level. There are people who think one way and people who think the other way, that it was always there lurking in the background, the initial biopsy didn't show it, and then others showing that it really evolved out of a pure adenocarcinoma.
Hey, Dr.
Wayne?
Gandara.
I got
So
you done.
how useful is the NGS info in a later line treatment setting? Because I know that having that information up front is really helpful in a first line setting, and maybe T790.
Put your mic up to your.
But you know, for people who are at their third line, fourth line, is that information as critical?
Right. So again, a great question. This is graduate school level too. So I got a denial last week from one of the Blues on a patient who has an EGFR mutated lung cancer who had had prior therapy. She started with erlotinib, and then she had a T790M mutation in her cancer, so she got osimertinib, otherwise known as or
Tagrisso.
Tagrisso.
Yeah.
I don't have to.
And then
I don't know why.
she came to me and she was feeling much worse, but her scan was being read elsewhere as stable. So, and when I say much worse, she was becoming hypoxemic. She has a oximeter. And so her scan was being read, well, maybe you have pneumonia.
Yeah.
They said, well, maybe you have pneumonia. And so I had our radiologist look at it, and they said, oh, this could be the cancer. It could be what's called lymphangitic. So I got a blood test on her, and it showed the mutation which typically occurs after osimertinib, the C797. By this time, that was 7 days later, by this time she was hospitalized, or she was rapidly declining. She is one of those that turned into an emergency. So we put her on a treatment which we have developed, where you add what's called an EGFR monoclonal antibody to the osimertinib. This is part of an NCI trial that we developed. And within 7 days, her blood oxygen was back, she was feeling well, and within 2 weeks, she was back to working. The insurance company denied the blood test. They say there is no role. They say, we showed it to an expert.
No evidence.
There's no evidence that testing somebody outside the first line can help them.
Yeah.
It saved this woman's life.
Yeah.
Here's your evidence.
And she gave me permission to use her case
Let
to
me
illustrate
drive her to
this.
your office.
So, you know, again, you know, sometimes the system can help you and sometimes it can hurt you. One thing that my hat's off to for all oncologists in the US, we spend an incredible amount of time doing peer-to-peer reviews. Do you know what that is? That's when the insurance company says no. And you have to get on the phone and call them and wait for 30 minutes. And then you get somebody who's a general practitioner who's working for the insurance company. They aren't even an oncologist. And they've decided, no, we're not going to pay for this. So I would just say, go watch the 60 Minutes episode on what we call churning. It's probably in their archive. I won't say anything more about it.
So I have a question, and Dawn, I know you have a question. I'm coming to you next. This is based on what you were just saying. The sort of N of 1 information that you just gave off, is there a benefit? I know we have a lung cancer registry. It's patient-reported outcomes. But is there a benefit to physicians? Because all treating physicians have these sort of N of 1 anecdotal sort of, here's your evidence. But is there a way, like what could we do to help compile that information so that your argument is potentially more valid because it's no longer just one patient?
It's more than one patient.
Okay, so when I gave this patient example, this is backed up by 800 patients in one study, 500 patients in another study.
Okay.
I was making it personal.
Got it.
But what I'm saying is this expert knows these data.
Yeah.
He has chose to ignore them.
Right.
Which is a whole other problem.
There's a concern with the N of 1 in that that's discovery. It doesn't mean you should practice that way.
Yeah.
I am a little concerned because we want to do things that help the patient, but we also want to do things that we know are not going to be detrimental, just cause needless side effects. And so, Barbara will know this, there's an adage in oncology about you don't base your practice on what happened to one patient.
Mm-hmm.
It could tell you how to discover something.
Right.
In other words, maybe you reanalyze that cancer and you find a new gene that
And
helps.
now you can do a study on it.
But what I'm saying is the issue I was talking about retesting with blood is confirmed in many, many studies.
Exactly. And the major takeaway today is upon progression, test. No guessing. Don't guess, test.
Agreed.
Don.
Well, I was just going to say, Rick had mentioned whether it was one cancer that mutated or two different cancers. And with Penny in 2014, she had small cell extensive, but I brought her out here to California to Dr. Neal at Stanford. And she had a surface tumor underneath her right arm. Oh. And nobody else had tested it in a year and a half. Now, liquid wasn't real popular back then, and she was sensitive to having a biopsy. But finally, when Dr. Neal put a catheter in, he did test it, and it turned out it was neuroendogen. So not only can small cell or EGFR mute to small cell, small cell extensive can mutate to neuroendogen carcinoma.
Interesting.
I just want to mention one other thing. Back in the back here, you said BRAF. One cancer was BRAF positive and one was negative. Yes. So that's a very interesting thing. We see this all the time about, does this patient have two different cancers or do they have all the same cancer? And in the past, we had the pathologist study the specimens, do stains on them, and we tried to figure it out. So some of you know Valerie Roche, very famous surgeon at Memorial Sloan Kettering. And we had her out at UC Davis last year, and we said, this comes up in tumor boards, we said, how do you at Sloan Kettering, how do you decide if it's one cancer or two cancers? One that, when I say one, it's two spots, but I mean one that metastasized to the other spot. And she said, we do molecular testing, which is what we do. On both. Yeah, on both.
On both.
And see if it's the same or see if it's if it's different. In the case of the BRAF, it probably means it's two separate cancers. You can never say 100%. But again, I had a very nice example of this because I think we helped the patient who had a previous cancer, early stage, because we haven't talked about that.
No, we haven't.
In 2013, she had a stage 1 lung cancer. And the oncologist tested, and it was EGFR positive, but it was surgically taken out. She didn't have any more treatment. In 2019, she shows up with a very extensive cancer in her lung. And she was started on chemotherapy and immunotherapy. And I said, well, did you test to make sure that it wasn't the same cancer? And they said, well, no. And so we tested the blood, and it was the identical mutation, and it was an uncommon mutation. So So it was very unlikely. It was in both of those cancers. That means that this was a recurrence of the original cancer, because in 2019 she had what might be considered stage 3, and it would be treated differently than if it was a recurrence, where we would call it stage 4. So the molecular testing can help in many ways.
Yeah, always, yeah.
There are so many things that I want to talk about, and you mentioned at the beginning we could talk about this for 3 days and probably more than that. You just mentioned we haven't talked about the early stage disease and what that looks like. So whether we're talking about early stage, sort of locally advanced and or metastatic disease, there's multiple different ways to treat all these different sort of stages, if you will, and we haven't really dug into immunotherapy. We haven't dug into combination therapies too. Is there some validity in the sequence with which these therapies are given? Right? Does that have an effect on outcomes? All of these things, and I'm looking at the clock, and we've got like 15 minutes. So I'm going to ask you, Dr. Gandara, to pick sort of the next space that you think is most relevant today, and then when you come back.
So I'll just mention, because I know most of you, with a couple of exceptions, don't have early stage cancer. But I think the next breakthroughs are going to be in early stage lung cancer, stage 1 in particular, where the so-called adjuvant chemotherapy doesn't work. There have been several breakthroughs here. One is detecting minimal residual disease. Has anybody ever heard of that? MRD.
And does everybody know what adjuvant therapy means?
That means after surgery. After surgery.
So neoadjuvant is before.
Bonnie and I and Danielle were talking earlier about a very famous researcher in the UK called Charlie Swanton. And he has published some very nice data saying after surgery, we can detect things in your blood, mutations that were there before surgery. And if you're a patient where you had that mutation before surgery and then a month after surgery, you don't have it in your blood anymore, you're very likely to be cured. You may not need chemo. On the other hand, if we find that mutation in your blood, even though your scan looks peachy keen, that means that there's some residual cancer somewhere and maybe you do need additional treatment. So that's very exciting, because in the future we're going to be doing that. Right now, that's research, but it's moving.
So you're looking for cell death?
Yes. And then the other thing, I mentioned this earlier, is we have new gene testing capabilities in the cancer itself at baseline that can tell us how likely it is to come back after surgery. And I'm particularly proud of one of these. It's called RAZOR. Although I've renamed it, I call it Gene 14, because that's catchier. RAZOR kind of sounds like they're trying to say it's, like surgery.
Slicing you up.
But anyway, this Gene 14 is what we would call a prognostic biomarker. And I'm proud of it because it was developed by one of our close colleagues, Dr. David Jablons at UCSF.
My surgeon.
Wait, you're stealing my thunder.
Oh, sorry.
She does it all the time.
We're, Bonnie and I are both very good friends with DJ, as we call him, or Dr. Jablons. And I told him, in a little bit in jest, one time that he was famous for two things. He's famous because he operated on Bonnie Adario. Does anybody in the room except the Adarios know what the other most famous thing is for Dr. Jablons? And I hope he will watch this at some point.
What do you mean?
Goats.
He operated on Coco the gorilla from the San Francisco Zoo.
Yeah.
I won't tell you the outcome of that surgery, but at any rate, so those are the most two famous things.
And the third thing now is his cheese.
And his cheese.
And his goats.
He's
that's right.
He's making cheese. He's a multitasker.
Hey, Dr. Gandara, I had a question about blood biopsy. I think Rebecca had 3 blood biopsies done over the course of a couple of years, and it never found the KRAS in there. Is it a matter of sensitivity that they didn't find it, or is there an optimum window to where you should draw the blood?
Right.
how it matches up with the
So
cell death.
I'll just repeat the question, and that is, if the blood test is so peachy keen like I said it was, why didn't it pick up the G12C in this case? There are some patients. Oh, you're a D. Yes. I'm sorry. Well, why didn't it pick up the G12D? And in some patients, the characteristics of their tumor are such that they don't shed much DNA into the blood. And you don't find it, even with very sensitive tests. So it could be that that's the case here. I would guess that it probably is. Because I'll just mention this too. How many of you have ever seen like a Garden report? Raise your hand if you have. How many of you ever seen a Foundation Medicine report? Okay. So these are kind of the two most common tests that we use in people with advanced stage disease. And if you've seen one of these reports, it's about 50 pages long. They not only report what mutations they found, which are what we call actionable. In other words, we know that this is important in therapy. They report other mutations which we can't do anything about right now because maybe you need to go on a clinical trial that requires one of them. And then they report what are called variants of unknown significance. And that means, let's say for BRAF, there's this variant that nobody knows whether it's functional or not. Dr. Gitlitz found out that 2 of these variants of unknown significance for EGFR were actually functional, right? As part of the, so she's famous for that. That's pretty amazing.
She is.
So what they do then is they quantitate how much of that is in the specimen. And in blood in particular, a lot of oncologists don't realize that the amount of the mutation in the blood can be very low and it's still meaningful because you're comparing the amount of the mutated gene in the blood to all the DNA in the blood. Because even for cancer patients, the normal DNA is the vast majority. In other words, all of us in the room have DNA in our blood because cells break down, gets into the blood. Hopefully we don't have mutated DNA in our blood, but all of us have DNA in our blood. So oncologists, and this is part of our education mission, they need to know that it doesn't matter if it's 1% or sometimes even less than 1%, that's still actionable. And one of our colleagues, Dr. Agarwal from the University of Pennsylvania, just published a very nice study showing with all of these oncogenes, it didn't matter how much was in the blood, high or low, for the patient to respond. People who had low amounts in the blood responded just as well as the patients with high amount. So again, you now know more than most people.
Actually, a lot of physicians treating.
Right.
Yes.
I wasn't going to say that.
Yeah, I can say that.
I have a question about early stage lung cancer. I was found 10 and a half years ago, found very early, and had my lower right lobe removed. They weren't doing, most places, doing any molecular testing. What you're talking about with the blood and being able to see before and after, is that something that even though I had no testing, that this can be looked at?
It could be, but I don't think at this point it's going to be meaningful. I think if you're 10 years out, then, you know, hopefully you don't have to have that kind of testing because it's not going to come
Sally's situation, there's nodules that they're following, right? Or no?
Yeah, I have nodules in all my lobes, and I watched, my mother had it, and she had it 3 different times. I always add on, she lived 22 years with it, but, and I have other family members that have had it, so.
You mean lung cancer?
Yeah.
Oh.
Yeah.
Well, Dr. Gitlitz can tell you all about this situation.
Okay.
But in terms of the little nodules, if there's something that has been there a long time and it's not changing, then I wouldn't do the blood. But if one of them is growing, then the blood could be helpful, do you see, to help sort it out.
No, my oncologist said that he felt if my cancer came back, it would be a whole new entity and not one of these nodules.
So the Adario Foundation, together with Dr. Gitlitz, has published very interesting information about germline mutation. Do you want to just mention that, or?
That's the work of Jeff Oxford,
Oh, okay.
actually.
I'll attribute it to Jeff then.
But we'll tell you a really quick story about that, and it is with Dana-Farber and still growing. We, Jeff and also David Carbone felt that if you had an EGFR mutation along with a T790M, that could be a germline lung cancer. So,
And that what we mean by that is this not, remember when I told you you're not mutated, it's the cancer that is?
Yeah.
In the case of the germline, that means that mutation is actually in your normal DNA.
Yeah.
Which may or may not be important for a lot of things, but in this case, in some patients, it is.
And as opposed to what was previously thought T790M was what they call a resistance mutation.
Yeah. But long story short, there was a patient in David Carbone's clinic who had already been diagnosed 10 years previously with breast cancer, and now she was being diagnosed with lung cancer 10 years later. Blah, 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 blah. David called and said, she has a daughter in California. Can you get her in to see a geneticist and see if she has those markers? We got her in to see the geneticist. Yes, she had the markers. Next stop was a CT scan. Tumors in 2 lobes. And they did biopsy, and it was lung cancer. Did little wedge resections, and this is like 7 years ago, and she's fine. But this is lung cancer in situ.
Right, and that, again, this situation is rare.
Yeah, rare, but there. Rare, but there. Testing. Right.
And I hate to break up this conversation. We've got about 5 minutes left.
Can I say one thing?
Of course you
You're in charge.
You can say more.
You're in
than one
charge.
thing.
I want to return to the importance of the living room. I agree with the comments that have been made. Nobody else has this. This is incredibly important. Yesterday, I was in Santa Fe. My wife and I and another couple had gone to Santa Fe for the weekend, long weekend. We were going to come back tomorrow. We were coming back yesterday morning, and our flight got canceled from Santa Fe. So I got on the phone with United. I said, I have to be back today. You have to find some way to get me back because I'm speaking at the living room tomorrow night. And so we actually drove to Albuquerque and got a flight from Albuquerque to LA and then LA to San Francisco.
That's awesome.
But it was very important for me not to miss this.
And it's important for us to have you here as often as you come because it's important for everybody here and important for the people online. And education is power, and educated, empowered people live longer.
Absolutely, and we couldn't provide that without you and you, Dr. Gitlitz, and others like you to come in and talk to everyone. So huge thank you.
You were going to tell us about the fisticuffs you got in with Barbra.
Oh, yeah, the debate.
A debate.
Can I close this out just for purposes of TV?
Okay,
before,
and then I'm
going to come back. I'm not going to close out the whole meeting. I just have to say a couple things within a 2-hour time frame.
Before the video shuts off.
Yeah. So the one thing I want to point out, and Esther, you'll be next, is if we've learned nothing else tonight, which I think is not true, because I think we've learned a lot tonight, it's how very, very complicated this disease is, and how very, very important it is that you are with a physician that you feel comfortable with, and that you can have these types of conversations with, and hopefully has the benefit of having lung cancer be one of the things that they specialize in. There are so many different types of cancers out there, solid tumor and blood cancers alike, and I think, I say this all the time, but I think it's personally unfair to expect a general oncologist, in private practice to know everything there is to know about all of those 100, give or take, types of solid tumor and blood cancer. So please, you don't always even have to have your primary care team be a specialist like Dr. Gandara or Dr. Gitlitz, but you can consult with them and then go back home into your hometown and get those treatments there. But it's very, very, very
almost all oncologists will support people getting a second opinion.
Second opinion.
This is not, it's not diabetes, it's not heart disease, it is complex. I don't want to say those are not complicated. It's more complicated.
Yeah. And to
So,
add to what-
you can always get a second opinion. And I have my patients who want a second opinion.
Yeah.
And I say, get it.
And
please.
any
He sends
physician,
them to us.
yeah, any physician who's going to be upset at the mention of a second opinion is probably means you need to be getting a second opinion anyway.
And new testing upon progression. Always demand a test.
So I'm going to do next up, and then I'm going to go to SD. We already talked about the Latin America Conference on Lung Cancer, where Thursday evening Central Time, or Thursday afternoon Central, we will be at 1 p.m. Central hosting a living room from the conference. It will be all in Spanish, so if you don't speak Spanish, there's no need to sign into the through the live stream. However, we'll be doing the exact reverse of what we do here, and we will be we'll have the text, the subtitles, thank you, in English upon the edited version. So we're really excited about that. It's spearheaded by Dr. Reyes, who you guys have heard us talk about from Memorial Cancer Institute in Hollywood, Florida. Dr. Clarissa Mathias, I'm going to screw this up so bad, from Núcleo de Oncologia de Bahia in Brazil.
That's Salvador Bahia, if you've ever heard of it. Fantastic place.
In Brazil,
And
I've never even been to Brazil.
Dr. Matias is the first Latin American representative on our board of directors for ISLC, and I was the head of the nominating committee.
There we
so
go.
I feel a little responsible. Anyway, she's fantastic.
And then Dr. Arrieta from the Instituto Nacional de
From the NCI
Cancerologia.
Mexico.
Thank
Yeah.
you,
Yeah,
Mexico.
you're right.
I was trying to do it in Spanish. Anyway, we're really excited about this, and Dr. Arrieta and Dr. Reyes, Dr. Reyes has been spearheading it from the U.S. for us, but Dr. Arrieta was adamant about not closing registration because there's such a need for this type of information in and around even just Mexico City. So we have registered 162 patients and caregivers and 88 delegates. So there's obviously a huge need for this type of forum down in Mexico. So it might even be worth, just if you're perusing through Facebook and you see it come up, just watching for a little bit.
And if everyone's smiling, it's going great.
Yeah, Michelle and I will be listening with the people translating with
Es
little
bueno.
earbuds. Yes, es bueno.
That's bueno.
And then next month's living room, November 19th, we're going to be talking a little more in depth about what we're talking about today from a research perspective, and what happens and how do drugs and these therapies go from the lab to the patient? What does that process look like? And Dr. Amy Moore is going to be on that panel with Dr. Leah Crystal from Amgen. So we're excited about that. Events, 5K, Hollywood, Florida, and Houston on November 2nd. So anybody watching who's in South Florida or down in Houston that wants to participate, or anybody watching who knows people in those areas that want to participate, please reach out. Our gala is November 9th.
I know.
So we're very, very excited to see those of you that are going to be able to make it. Are you coming to the gala this
Yes.
year? Absolutely.
Of course
Okay.
he's coming.
Well, I didn't know. Sometimes things happen. And then, of course, I want to give a huge thank you, patients, caregivers, for coming out. You are why we do this every day. And it remains our favorite day of the month, every month, even when we have to travel to do another one in 2 days in the same month. It's
family. You're all
it is.
family.
It's really
I hope you think of us that way.
And a thank you for the feedback tonight on what this living room means to those of you who shared feedback. Larry almost made me, well, not almost, you did make me cry, and I was like, man, I don't have tissue. It's sort of what I hear from industry from time to time about why they like to come and sit in these meetings, because it reminds you, not that you need reminding, but it's a place to remind you of how important what we're all doing is. So thank you all for that feedback. Huge thank you to Peninsula Television once again for coming out. The door is closed over there. I hear Rocky in the back. For coming in and setting up the TV station in the storage room back there so that we could bring this to all of you out there through the live stream. So thank you to Penn TV. Thank you to the Office Bar and Grill for providing, once again, the pasta dinner, the monthly pasta dinner. And then I have to thank our supporters. So I need to thank Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Celgene, Dignity Health, Genentech, Lilly, Merck, Novartis, Oncocyte, Takeda, and Tesaro.
Oncocyte.
Yeah. Without their support, we wouldn't be able to bring this to you, and it's huge. We do. We touched on this a little earlier. We do 12 in this room, so once a month in this room, and then we do 6 regional living rooms, including the 2 this year outside of the U.S. And it's a ton of work. A huge thank you to Michelle for all of the work that she puts into to what happens in order to get us all in this room with these amazing speakers. So thank you, thank you, thank you. Of course, huge thank you to Dr. Gandara for coming out once again. I already have my idea for next time you come back. All the things that we didn't get to talk about today, that his opinion, I know how much I respect his opinion, and I, of course, know how much you all respect his opinion. So huge thank you to Dr. Gandara.
And just remember, it's an opinion.
It is an opinion.
Yeah, sure.
Everybody's welcome to stay for dessert. Sally, do we have dessert? Did you bring dessert this time? Sally. Sally brings dessert every Tuesday. And Ron Fong, although his hat's being represented, or Joan's hat in the room, sometimes they have wars over who's the best dessert.
I think coincided with a debate tonight. What she says. She has no idea there's a big debate going on TV tonight.
Oh, you mean you're not talking about Dr. Gitlitz?
Right.
Yeah, that's where I was like, cancer?
I am talking about that because I know exactly what you're going to say.
But I want Esty to be able to ask her question. Sure.
Microphone. Oh, we're off live.
No, we're still live.
We're still live.
I'm special because Dr. Gandara is going to be here. I always try to come. I came back from the city. I was at my home in the city. But anyway, I have this question. Number one, I forget that I had lung cancer. I don't even think about it. I mean, I hear. So I am not well formed on anything that's going on, because if I don't have a problem, I don't think about it. I think of other things. So I still have all these spots that came after my surgery. I never had chemo and I never had radiation. I just had the top lobe removed and so on. So it was stage 1 or something like that. From everything that you were talking about, I'm trying to figure out, am I supposed to do something? I don't talk to anybody about it. I just, lung cancer.
Well,
oh, yeah, I had lung cancer.
I think you said something very wise. Again, there's a lot of wisdom in this room. And that you said, I forget I had lung cancer.
Yeah, I don't think about it.
So it doesn't matter whether it's stage 1 or stage 4.
I don't think about it.
Part of what we want to do is allow you to live the best life you can for the longest that you can do it.
That's what I do. And I think I visualize, number one, to live a long life, you have to want to. And you digest your thoughts just like food. Thoughts are they're not just blah, blah, blah. Einstein said to think is to create. You create by your own thinking. If you want to live a long time, you have to visualize that you will. You don't doubt it. If you plant seeds, you don't. If you plant seeds of potatoes, you don't expect tomatoes.
So, I like that.
You know, so it depends what kind of seeds you plant.
Yeah.
You don't dig them up. You let them.
So you have converted lung cancer to a chronic disease. That's what we want to do for everybody.
Right. I don't even think I have a disease.
So Don has had more treatments for his lung cancer than any patient that I've seen in the past.
Okay. Exactly. So my question, I want to make it short. My question is, since I ended up a few years later with all these spots, ground glass here and they've been for 6 years, for 7 years, and one of them they didn't like, and so. So all this information that you gave out, is there anything I should be doing to find out what I have?
This is very common. Some of you probably, other patients probably have this. Now that we have better scans, we're finding these little abnormalities in the lung, which had been there all along in other patients, but we couldn't see them because the scans were not sensitive enough. And they're referred to as ground glass opacities, or GGOs. Sometimes they're a little bit of inflammation, a reaction to something. Sometimes they're an abnormality we call AAH, or atypical alveolar hyperplasia, which could, in some patients, turn into a cancer. And sometimes it's a cancer that is, somebody used the term in situ earlier. In other words, a kind of a malignancy that is pre-malignant or so low grade that it's never going to bother you. And then sometimes it's a real cancer. So we have much better ways of distinguishing them now. Is it part solid or is it completely this ground glass? And if they are concerned enough about them on your scans, they will recommend follow-up. And if one of them changes to the point where it's suspicious, then they'll act on it in whatever way, whether it's a biopsy or whatever.
I've had them for about 10 years, I think, 6.
And they're following up with you, though. You get a scan
The one,
like every 6 months?
once a year I get a scan.
Yeah, and I do
get a
that for many
CT
of my
scan.
patients in the same situation.
Once a year. And they, you know, I don't have any special doctor at Stanford. I just go there once a year and they take the CT and then they tell me, but they said I have quite a few of those, and I've had them for quite, and I have EGFR, I guess that's what they called it. My cancer was, and the only place they were able to test it was at Dana-Farber. Stanford couldn't test it, the block. They tested the block. And they said it was EGFR, something like that. So I don't have to do any of the stuff we talked about.
I think that what they're doing with the yearly scans is the way to go.
Just watching.
Just the yearly scan.
And in the meantime, you don't have to focus every day on your cancer.
Right.
I don't.
You know, live your, no, I'm talking about, I'm in general, I'm telling people.
I forget about it.
Follow this example.
There you go.
I forget about it because it doesn't accomplish anything.
Yeah.
What's the point? I don't dig up stuff and think about it. I don't give it energy.
Power of positive.
I don't give it energy.
Thank you, Esty. Everybody, dessert is back in the corner. Thank you all so very much.
We want to hear David and Barbara's.
Oh, we forgot to hear David and Barbara's story.
So I'll just make this short.
Difference of opinion.
Barbara and I, we have this meeting called the International Lung Cancer Congress that's held in Huntington Beach every year.
She's got her mic. She's ready.
And sometimes we will have debates. And about 3 years ago, we had a debate on testing for immunotherapy. And I gave my debate. I was very scientific. I didn't denigrate
No, he took the high
Dr.
road.
Getlitz.
Yes, he
And
did.
then she gets up there. And
took the
she
low
says a few
road.
words, and then she starts saying that about her mission in China, where she's rescuing the dogs from China, which is all really important, but she got the sympathy vote. This is the only time I've ever been defeated in a debate.
And then I was outside of the room, and you came out and asked me if I was gloating. I was.
That's great. That's great.
Wasn't there another time when Barbara said something about EGFR and exon
20 insertions
on a panel at the lung
Barbara's
cancer
like, yes,
Congress?
there was. There was a time. She remembers.
So, you know, with more and more testing for EGFR, you know, I did this case where someone has an exon 20 insertion, they come to you and the person's already started on an EGFR inhibitor, and do you shake their hand and tell them that, great, you know, do you stop it and start them on chemotherapy? And almost all of the oncologists said, yeah, continue the inhibitor. But, you know, it was a while ago.
Yeah.
You know, it was just awareness of exon 20 insertion.
Yeah, interesting.
Yeah.
Interesting. All right, dessert.
Thank you all.
Thanks, everybody.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest, like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.